tumor that is invading the bones, and in that case, that there would be a wide range of differentials for that, depending on the patient's age. So yes, this could be a primary bone tumor as well. I don't think it's an infectious cause, and I'm not suspecting any other non-sinister pathology in this instance. Less likely.
Primary bone.
It can also be metastatic to the point of apologies.
So they're bilateral. So at least one would be, if they were primary, you're saying one primary bone tumor that was metastasizing to different ribs?
Possibly, or it could be a malignancy elsewhere that has metastasized to the ribs. And actually, looking at the I'm just trying to see if there's any other abnormality that I can spot. Okay, so looking at the CT scan, there are multiple destructive bone soft tissue densities based in the rib cage with destruction of the adjacent bone, and they're more apparent. I can also see a right paraspinal mass. In the left kidney, there is a enhancing mass, and I would like to review it better. Yeah, so there is an enhancing mass, and it has sort of a central enhancement. I'm suspecting an RCC in this instance. Normally, I would look to see if there's any adjacent lymph nodes. And I would check to see if there's involvement of gerotis fascia, as that would change the classification. I would look for other lesions, and I would interrogate this in a coronal view. And apart from that, if I'm only given this and there's no abdominal imaging, this is as far as I can take this image.
Okay, so what about so you're suspecting an RCC with bone metastasis, I'm guessing?
Yes. Yes.
So what are the typical, what is the typical word I want you to say when you're talking about RCC?
Lytic bone mets. Lytic bone mets, is that what you want?
And
hypervascular metastases as well.
So hypervascular is more when they're in the organs. So for example, if there's a lung met from RCC and you try to biopsy, they tend to bleed a lot. But if it's in the bone, the typical appearance is an expensile met. So if you think of the organs that can give you expensile bone metastasis, do you have a list for me? One or two?
The malignancies that can give expensile bone metastasis?
Expensile bone mets, yeah.
Could it also be thyroid malignancies and potentially breast as well, but I'm not quite sure, to be honest.
Okay. So what would you do next?
So next, I would request a CT abdomen and pelvis. I would refer this patient to the urology team. With the CT abdomen and pelvis, I would probably like to do a triple phase scan, so a urogram, just to assess the renal tract and exclude involvement. Refer to the MDT urology review, and potentially a biopsy could be taken, and potentially from one of the soft tissue lesions in the bones.
Any other imaging you want doing?
I would also consider a PET scan just to look for any other lesions.
Anything else to make sure the patient is walking next week?
Oh yes, I'll check the bones and check the spine. So I'd look at the sagittal imaging as well. Is that and also here I can see that the spinal cord is involved with the soft tissue mass, and there's an invasion of the thecal sac. And complete soft tissue opacification of where I would expect the spinal cord to be. I would be very worried about spinal cord involvement, and I would contact the orthopedic team, alert them about this patient, and then follow up with further imaging, potentially an MRI, to assess the spinal cord.
Okay, well done. Let's move on to the second one. I think you got everything right. The description I wanted straight away was multiple bony lesions, because I think in this one it's quite obvious the bone is missing here, and that's why they look so clean. That's why you pick them straight away, because there's no bone behind it. The description was, if this was the only abnormality, I would buy the pleural-based obtuse margin, etc. But here the bone destruction, and here it's quite clear. So I was looking for bilateral aggressive lesions causing bone destruction. I'm concerned for underlying malignancy, metastatic or primary bone, or whatever you wanted to. But after that, I think the CT obviously caught up very quickly. In terms of safety, the RCC was right at the edge of the chest, so that was the one completing it all. Expansile bone met with a left renal lesion suggestive of renal cell primary. And you have to always think of the spine, because you always want to not miss the thing that keeps the patient safe. Don't want to make a mistake like that and get everything right and miss the spine bit.
Yeah.
Because that makes it hard to then give you high score or otherwise a case. Very well done. I will give you a harder one.
Oh no.
Okay. So this is, let's see without history. Then I'll give you the history if you ask for it.
Okay, I am presented with a frontal radiograph of the chest. There is no obvious abnormality that is apparent to me. However, I do notice that there is increased reticular nodular opacity in the periphery of the lungs bilaterally, and there is also I forgot the name for it. The line for long-term portocath in situ. In the presence of the portocath in situ, I'm thinking about patients that need long-term medications. Administration of IV medication. So looking at the lungs, I can actually appreciate bilateral tram-like and cystic bone changes, most pronounced in the upper and mid zone. In the right periphery of the right mid zone, I can appreciate a focal opacity with central lucency, and I wonder whether that could be a cavitating lesion. I'm also looking at the lungs to see if there's any further opacities, and I suspect that there may be an opacity in the right lower zone, just behind one of the ribs, the lower ribs. Looking at the left lungs, there's no further changes. There's no hilar lymphadenopathy, no pleural effusions, and in summary, this is a patient who has a post-portocath with bilateral cystic bronchiectasis and a focal opacity in the right mid-zone peripherally, and a suspected further opacity in the right lower zone. I would think about cystic fibrosis in the first instance, and with the cavitating opacity that I would be worried about atypical infections. I know that cystic fibrosis patients are prone to ABPA, and they're prone to aspergillomas, and they're just prone to normal sort of bronchiectasis and infections associated with that. So I would like a CT scan to further characterize.
Okay.
I'll just wait until, if that's okay. Okay. So axial plane CT scan of the chest, bilateral cystic, so bilateral traction bronchiectasis with cystic bronchiectasis, most pronounced in the right mid zone, where there is also associated patchy opacities that have the appearance of tree and bud nodularities. And there was also one of the cystic bronchiectasis, actually both bilaterally, there's endobronchial thickening and further thickening around the cystic atypical infections in these patients.
What is endobronchial thickening?
Endobronchial thickening is...
you mean bronchial wall thickening?
Bronchial wall thickening, yes. Yeah, sorry.
And you mentioned traction, bronchial dilatation, and bronchiectasis.
Yes.
So you have to pick one, I'm afraid.
Yes, you're right. I think, sorry, there's cylindrical and cystic bronchiectasis.
Yeah, exactly.
What I apologize.
So when you say traction, you're implying ILD, and the patient
Yes.
doesn't have ILD. Yeah. So yeah, I think, and I think you picked this tiny region as well on the radiograph, which was good. Yeah, bang on. I think the portacath is a hint, but you can't say I got the case because there's a portacath. You have to be a bit more. It's a subtle hint. So you can't bank the diagnosis on the fact the patient has a portacath. You can say it later on, but don't let it be the reason you say cystic fibrosis. Although that's why we all do it, but let's make it not that obvious.
Yes.
I will give you another one. Wrong one. Okay, 1 second. Okay. Okay. Shortness of breath.
I'm presented with a frontal radiograph of the chest. Although this is an AP erect film, I think the patient does have a degree of cardiomegaly. There are bilateral reticular opacities or interstitial opacities, and I can appreciate curly B lines, most pronounced in the right mid-zone. I think there is also a degree of upper lobe diversion. There's no pleural effusions. I'm looking to see if, so there are features here in keeping with pulmonary edema, but I would like to see if there's any other abnormality.
Okay, so the patient doesn't have any other abnormality on the X-ray, but they are a known heart failure patient, and they are now septic with Rigers.
Okay.
Yeah. So I'll show you the CT file.
Okay. Right. Okay. So bilateral. Sorry, I'll just have a better look at that. Okay. Can I just see the left main pulmonary artery as well? I just want to see if there's.
It doesn't go high enough. It's a cardiac CT.
That's all right. Okay. So there are, so left pulmonary artery demonstrates a central filling defect in keeping with an acute pulmonary thromboembolism. There are wedge-shaped bilateral posterior basal consolidative and ground glass changes with areas that have sort of interlobular septal thickening. These are in keeping with pulmonary infarcts in the presence of pulmonary embolism. I also noticed that in the left kidney, there was a wedge-shaped area of hypoattenuation that is extending to the renal cortex. I cannot appreciate a cortical rim sign. I would interrogate the left renal artery in detail to exclude a filling defect. However, this appearance to me is suspicious for a left renal infarct. So in summary, there are multiple, there are pulmonary and renal infarcts. In a patient with heart failure, I would be worried about thromboembolic causes, such as atrial fibrillation or an irregular heart rhythm. It is I would interrogate the heart to just exclude, atrial septal defects or any other abnormality, but I can't appreciate that. And I think there is also a filling defect in the left ventricle. Which I suspect is most likely a thrombus, just because this will be the most common etiology. Having said that, I would like to interrogate it and assess its attachment to the, if there's any attachment to the adjacent muscles, which I cannot appreciate any attachments. So this is likely a thrombus in the left ventricle as well.
Mm-hmm. So what are the infarcts then?
So could the infarcts be this thrombus is throwing off microemboli and causing infarcts?
So what are you concerned about in the patient's history?
So I would be concerned about a possible etiology. So what is causing the thrombus? So what causes of thrombogenesis or having an increased risk of thrombus? So atrial fibrillation would be one. Is there a myocardial infarction or an aneurysm secondary to previous infarct? And actually looking at the cardiac wall, is there some thinning of the, I could be overcalling here.
No, it's dilatation because he's in heart failure. It's just a dilated LV. But in terms of history, are you concerned about any underlying drug history, or would you think that?
I'm thinking about. So first, I would review the patient's biochemical markers if they're available to me, and just check that he's not in a hypercoagulable state. Other things that I would think about would be medication that would cause thrombogenesis. Is that what you're hinting at? I'm not actually. I haven't picked it up.
No, that's you digging a hole.
Okay.
Can you think of a medicine that gives you thrombus in the heart? I'm talking about drug abuse. Okay, last one. Have a go. We have 4 minutes. I think we can squeeze this in.
Okay. This is the last one? Okay.
Yeah.
I thought it was the one I saw previously.
No, this is in, so I want to see if you got
right. Okay. So I am presented with a frontal radiograph of the chest. There is a right peripheral opacity abutting the right chest wall with an obtuse margin to the chest wall and some pleural thickening in that region. I suspect that this is a pleural-based mass. I can't see any underlying destructive bone changes, but because I can see underlying pleural thickening, I am looking to see for signs of previous asbestos exposure. And actually in the left lower zone, there is a irregular opacity that could be a holly leaf sign in the left lower zone, which might represent. I would normally window to look at the hemidiaphragms to see if there's any pleural plaques in that region. Elsewhere, I can't appreciate any hilar lymphadenopathy. And there's mild blunting of bilateral costophrenic angles, which might represent a small pleural effusion. So in summary, I have a pleural-based mass with bilateral calcified pleural plaques. My primary differential in this instance would be a mesothelioma, but I would like to correlate to previous imaging, as I also know that there is one other differential for a benign pleural-based mass, such as a pleural fibroma. So if I can have a CT, it would allow me to better interrogate this lesion.
So on the X-ray, one patient ago, what was the mistake you made?
I immediately didn't recognize that the mass could have another differential, that it had obtuse margins.
You didn't pick the bone destruction.
Yeah, I didn't pick. Is there bone destruction here?
Where is this rib?
Which, oh, yes. Okay, that one would have been a bit advanced.
So this,
Yes,
the minute you see an obtuse, you want to either call it cancer or not cancer. For that reason alone, you need to stare at the ribs really closely, over and under a lesion. Whenever it's peripheral, the margins are quite obtuse. Like you said, they're well defined, so it's clearly not in the lung. It's either in the pleura or it's in the chest wall or outside. You have to pick up the bone destruction. It changes it completely. And this is it's not subtle. It's very clear. And this was 5 minutes ago. A repeat of the same thing. And I'm glad I checked you. You made the same mistake again.
Yes.
You have to pick the bone destruction. If you pick the lesion.
Yes. I could not appreciate that, but I will look into practicing it.
So let's see if you say the right words to describe it.
Yes. So in the right chest wall or the right ribs, there is a soft tissue mass that is expanding the ribs, which is suspicious for an expansile bone mass. It also has some peripheral areas of calcification, but I think that's residual rib. I would look at the other chest. I would look at the other bony structures to see if there's any further lesions. Particularly, I would interrogate the spine to exclude any spinal compression or pathological fractures.
There's nothing else wrong with the patient. It's only this isolated abnormality.
So in this instance, I would look at the lung windows. I would interrogate the hilum and to look for a primary in my immediate imaging. And then I would do a CT abdomen and pelvis with contrast. And I would, then in that case, if everything has been excluded and there's no other primary found, I would think about a primary bone tumor. And in this age group, I'm sorry?
For example,
in this age group, because I think this is an elderly patient, just looking at the chest X-ray. So I would think of myeloma as the second most common differential, a plasmacytoma/plasmacytoma if it was a solitary lesion, and I think it is because we've just said there's nothing else. And so in that case, I would refer to the relevant MDT, and I would biopsy the lesion.
Yeah, this is biopsy proven plasmacytoma. So, okay, well done. But the take home message for you is the have to pick the bone, because that's what decides malignant versus when the margins are this smooth. It could very well be a benign lesion. It could have been there 10 years ago. But if you pick that bone destruction, you can very quickly get out of the X-ray, escalate, and move on to the next case. But yeah, well done.
Thank you.
I think we're right on time. Thank you, everyone. Does anyone have any questions about these last 4 cases?
So the chat is open. Any questions, please ask freely now. This is the time.
Can I have a go at the questions now? Do you want
Yes,
to?
please. Yes, please.
I have a question.
Take your time, whatever suits you.
Okay, the first question is, I have a question about the military TB case. On the CT, there was a mention about tree and bud, but the diagnosis was military. I think the word is miliary, and you're writing military, so that's one thing to correct. We have to call it miliary TB. Miliary TB is, like you said, hematological spread. The patient does, when somebody is immunocompromised, they have a bit of everything going on, and this patient was actually reacting to a drug as well. So this was a mixed diagnosis of hypersensitivity with superadded atypical infection. But in miliary TB, you should not have tree and bud. In endobronchial spread of TB, you have tree and bud and all these nodules. When you have central lobular nodules, that implies that there's something inside the airways. So yeah, that's if that was TB. It wasn't miliary. It was endobronchial spread of TB. Is the lower right vasculature on this chest X-ray normal? Yes, it is normal. This one on the screen right now, this is normal. With age, you get this sort of blunting of the diaphragms bilaterally quite commonly. But like the last candidate said quite rightfully, you have to say, it could represent small pleural effusion, but this is just common pleural thickening in elderly patients. This right lower lobe vessel can look quite prominent in many people, but this is normal. If you are concerned that it looks prominent, you try to follow it. If it's something linear, the likelihood of that being a vessel is more, and then you follow it back to the hilum and think what lesion can look like that. I can't think of a lesion that looks linear like that is coming out of the hilum towards the base, so it can only be a vessel. Isn't myeloma plasmacytoma a purely lytic lesion? Why does it appear soft tissue density in the final case? A lytic lesion is something that destroys the bone. When bone is destroyed, it doesn't result in air or fat. It looks like soft tissue. So it doesn't calcify, it's just the bone expands and it can look like soft tissue. Miliary can be ground glass. Yes, it can be. How to differentiate between collapse and consolidation? That's a good question. Usually they both happen at the same time. So that's one way to get out of a tricky spot. If you can't make up your mind, something has to have consolidated before it collapsed. So it's quite common to see in reports there is collapse consolidation. Collapse doesn't always mean there is something wrong with that part of the lung. Collapse can be secondary to something proximal to the lung. Collapse just means that part of the lung deflated. So collapse has to cause volume loss. That part of the lung has to get smaller. Consolidation alone is replacement of the air spaces with something else. It could be blood, it could be pus, it could be blood, water, or inhaling something, or a reaction, exudative collection inside the air spaces. So consolidation means normal lung volume air is replaced by something else. Over time, that part of the lung gets so underventilated that it starts collapsing. The body starts pushing air into it and just gives it a lower volume and it collapses. So the way to differentiate on X-rays, you want the fissures to move. The fissures have to go towards that area of abnormality, and that means collapse. Sometimes in consolidation, you can have increased volume as well, and that's a very typical sign of a certain infection. I don't know if you guys remember it or not, but when you say consolidation that is causing increased volume or bulging of the fissures, that's a typical sign for Klebsiella pneumonia. So that may be something you get asked, is a consolidation that has a mass effect or is pushing the fissure. You have to think of cancer, and if it's an infection, it would be Klebsiella. So I hope that answers your question. Would you consider brown tumors if old and class fibrous? Yeah, you would. But that's a discussion for the VIVA. Common things commonly is myeloma more common. Fibrous dysplasia, you tend to get asked for more for pelvic bones, or it's a more heterogeneous appearance. But obviously, anything can look like anything. On this last case, why could this not? I can't keep track of the chat. It's moving too quickly. For the sarcoidosis case, silicosis and cold worker can also cause lymph node calcification. Was it the posterior predominance that made sarcoidosis more likely? Yes, absolutely. It was a typical appearance. In cold workers, pneumoconiosis, you tend to get lung calcification as well. That's something sarcoidosis does not tend to do. The nodules you get in pulmonary sarcoidosis, they don't tend to calcify. Whereas in cold workers, you tend to get lung nodule calcification as well. And the lung is a bit more rough looking, dirty looking, scarred looking. What management can we suggest for end stage sarcoidosis? Nothing, it's irreversible. And those patients are usually under follow-up. Sometimes they tend to get a flare. So somebody with stage 4 sarcoidosis can have a flare and they can develop parenchymal or the nodules again. And that's when they need treatment. But purely fibrotic sarcoidosis does not have a treatment. Posterior lung fibrosis, why not post-respiratory distress syndrome? Because it wouldn't be upper lobes. Post-ARDS, lung tends to be posterior. Yes, you're correct, but they don't tend to favor the apices. It doesn't go that high. Ma'am, can we have one time? Of course you can. It's up to Dr. Sami to invite me back. I'm happy to come back. Post-lung fibrosis, why not TB? It can be TB. In TB, when you get fibrosis like that, the lung has cavitation. The lung has a lot more asymmetrical scarring. You get bronchiectasis, you get scarring and cavitation. So I can show you a case next time for TB to put it side by side so you can appreciate it. But yes, purely on X-ray, yes, you can talk about TB. But when it comes to that CT, you should think of sarcoidosis only. On this last case, why could this not be a pleural met with rib restriction? It absolutely can be, absolutely. And if I was the candidate, I would have said pleural met with rib destruction or a bone met, vice versa. It definitely can be. You cannot differentiate purely on X-ray. But the take-home message should be that if you see that on a chest X-ray, you have to pick the bone destruction and you have to call it cancer. You have to escalate appropriately, considering the patient likely has cancer, either primary or metastatic. So it doesn't matter whether you call it pleural or bone, you can't differentiate on X-ray. Can't see any more questions. Sigmoid or cecal. Go back. I've anonymized the cases now. I can't find them. Can't find the case for some reason. What are the differential for expansile meds? I think the last candidate answered that quite well. She said renal, thyroid, breast can cause pretty much anything. Breast is the only primary that can give you sclerotic and lytic bone metastasis. So if in doubt, breast can pretty much cause any kind of bone mets. But the differential the last candidate gave was pretty accurate for expansile bone mets. Please tell me how to differentiate interstitial lung disease from lung pneumonia. That's probably a lecture rather than a 2-sentence answer in terms of differentiating interstitial lung disease from pneumonia. But the simple answer is consolidation. You want to see haziness and on a bigger scale and consolidation to call something pneumonia. Interstitial lung disease needs to give you a reticulation that gives you lower lung volumes. You need to see reduced lung volumes to go down the ILD route. If you have haziness, general haziness, you need to talk about pneumonia, or if in doubt, pneumonitis is a good word, because pneumonitis doesn't really commit to infection or idiopathic process, because in the beginning, ILD, like drug-induced or something, can look like pneumonia. So pneumonitis is a good word to get out of that situation. But differentiating ILD from pneumonia is a long conversation that we can probably pick up another time. That's okay. Okay, thank you.
So, Samavia, that is, I think, all. There is a, what is this? The nitrofurantoin induced ILD. Okay, that is just a comment. So, thank you very much. You can hear me, Samavia. You can.
Yes, I can.
So, yes. Fantastic session. Thank you very much. And you have already promised them a session. So, we will, of course, the invitation is on. And on popular demand, I hope to see you soon. We will discuss whenever is your availability, another session whenever it suits you. So thank you very much. I believe they really, the teaching points, the learning points were actually learning points for myself also. And chest, I believe, is the most commonly asked single examination in the exam. And chest X-ray, of course, is the most popular. So I think they will need more sessions from yourself, and this will be extremely useful. So thank you very much once again.
Thank you for having me. Thank you, everyone.